Thank you, Roger. Thank you very much, and appreciate the opportunity to talk to you today. First and foremost, emergency care is something that we take for granted, but it's a very large and important segment of the healthcare industry. And so while we look at a lot of other things, what I want to do is bring your attention to the healthcare space of emergency care, which is very much time sensitive and therefore much more amenable to some of the opportunities we see with telemedicine. So just to let you know, we're in the transition right now of where we're not having a cyclical change in healthcare, but we're having a structural change of healthcare. In fact, a few years ago, if you went in the market space, you'd probably not see much change occurring, people thinking about it, but now it's in full gear, and it's a significant time. We have a bit of a tipping point, and what's more important is that it's changing the shift of focus from just activity-based to value-based, and that means there's a business model that's occurring that also supports the role of telemedicine and the way we do it. There's also a great opportunity for leadership, since people don't quite know how to apply telemedicine and some of the emerging technologies to the redesign of the healthcare system. So I wanted to start with this real quick. I was at GlobalMed. We had a large group of older physicians and senior executives, and we were talking about what happens in healthcare now, how we take care of patients, how we transfer patients, how we do our best job of getting the right resources and the right patients in the right place. And there was a medical student on the far right of this picture, and really no one asked any questions over a two-hour period. So at the very end, Roger Downey said, to the medical student, no one's talked to you, so what do you think? And the answer was, I think what you do is stupid. And that became kind of the mantra of looking forward to what we do. There's a whole generation that doesn't see the world we do because they are much more able to embrace the technology. And she said, look, I've got my phone here, I can push a button, I can talk to the bank, I can get my information, I can share information with colleagues of mine, all these things I can do, and what you currently do is stupid. What I want to do is show that she's exactly right. So if you look at the healthcare debate really did not focus on emergency care. It focused on the uncompensated, uninsured, and it focused on chronic care. And so the chronic care was all about the medical home and how we're going to send everybody in and they're all going to be fixed. But that's really probably not going to work. In fact, emergency care was relatively ignored. So let's look at the state of affairs with emergency care. Remember now, 4% of the physicians take care of 28% of the patients acutely and 11% of all the outpatient care. So that's a bit of a burden that we have to do a better job of. So where are we now, where do we go, and how do we get there? So with that, let's look at some of the forces in the marketplace. People are really concerned about health reform, but health reform is only one small part of it. Financial, I don't know anybody who wants to pay a penny more for health care. We've kind of tapped out and now we're going back down the other direction. We did this back in the 80s and 90s, and so you really have a different movement to different types of payments, different risk sharing, and then also the growth of the consumer as a payment source because they're paying more and more out of pocket with the high deductibles. You also see the social issues. Forget about Obamacare. You can't regulate the aging of the population or the growth of chronic diseases. These patients are much more complex. They stay in the ER a lot longer. They need more care, more consultation to be taken care of. Then the rapid growth of technology, which is the whole thing about HIMSS and ATA growing up. So the bottom line is you move from here to here, you have to evolve. And the driver for this in many ways is the financial ability to stay viable. So Dr. Brendan Carr and I wrote a paper actually that looked at all the changes that were needed in order to improve emergency care. We put it into health affairs, which is a very difficult place to get published, but it goes to the policymakers. So we went to the policymakers because a lot of the things that can be done need to be enabled through better policies. We start looking at it as a system as opposed to each individual facility. So what I want to quickly do is talk about some of the points and refer you back to the paper for more information. This is what I think is great. People talk about the growth of emergency medicine. They think it's somewhere around the 80s or 90s, but in the 1940s, when all these doctors came back from World War II, there was an expectation that the doctors would just be there and be available for the patients, but they saw the growth of the ER, the emergency room, with no one covering it, went up 600% over 10 years. And the reason why they went up 600% over 10 years was because the doctors didn't work nights and weekends, and people still needed access. And the funny thing is, in the paper they wrote, it comes out of Hartford back in the 1950s, they said, look, what's interesting is that 16% of these patients are being admitted. So the vast majority aren't patients who are life and death. And today, the number we admit is about 16% still. So there is a need, and so it's evolved. What I want to point out, though, over time it's grown, and then in the 1990s, which is really the focus of my talk, the 1990s, we began to look at regionalization. That is to cull out patients who needed special care. So regionalization, as we call it, 1.0, we found that if you take out patients who had time-sensitive conditions like a stroke or major trauma, cardiac arrest, you pull them out, you could provide better care to those patients. So really it was like very low frequency but very high impact for those patients, and trauma started and others followed. So now you see stroke and everything else, right? And they found it does make sense. You also do get better care. But the idea, the driving point was to get the right patient to the right place at the right time. And that became the mantra, and it was expanded for a lot of other things. At the end of the 1990s and somewhere in the middle of the 2000s, we began to see the limitations to this model, and that's what I want to point to you now. We're at a tipping point where the limitations are actually killing us out there. In the 2006, the Institute of Medicine started looking at emergency care, and they found several things. They found it was fragmented. They found that it was near failure. That was the original part at the breaking point. They found that there was lack of coordination of regional resources. They found there was large workforce shortages. So they began to make recommendations. What you found in some of the discussions we began to have was that we began to see that that evolution to get the right person to the right place at the right time had actually created a system where all the big resources were upstream, and downstream here you have a scarcity. And so they constantly sent patients up, and so when you started looking at it, of these patients who go up, about 70% are discharged from that receiving ED. That's a lot of transfers going up that erodes this down here. And it turns out you also not only erode them financially, you erode them in terms of capabilities and capacity because they don't take care of those patients anymore. So you have winners and you have losers. And it's nice to say they're winners at the top, but they don't get paid for the patient who gets sent up and gets discharged. They got worked up again. So the system is really unfair and doesn't work well, but worst of all, this is stupid, right? This is stupid. So here's some numbers for you. The numbers vary, but look, here's our critical patients, the top 15%. They talk about the people who don't need to be in the ER, but this is from the CDC and from the Center for Health System Change. You see only a small percentage don't need to be seen within 2 hours. So this large majority in the middle are being left out of any sort of emergency care system, yet those are the ones that come in and day out. And they encompass a lot of different symptoms that are called time-sensitive complaints. You got to figure out what it is. So abdominal pain, headache, fever, an injury, chest pain are the big number of patients in which you need additional evaluation, especially you don't have a surgeon, you don't have a cardiologist, they're not a STEMI, they're not a stroke, but they need evaluation, so they go upstream, right? They go upstream, and so you lose that patient locally. Those patients, as I said, are moderate frequency, moderate impact. So this is the ones we haven't designed a system for. And just to show you the numbers, there's a lot more of these smaller hospitals than there are the bigger hospitals. So this system, this one-way flow is all across the board, and these hospitals are doing what? They're going bankrupt. In Georgia alone, 21 of them will go out of business this year, and so it's a little bit different for them than it is for the people upstream. Here, again, all this can be read in the article, but if you look at the transfer rate, now look, the overall 16%, some are close to 16% admitted, but they're transferring about 25% of the patients who could stay locally. And so those patients are just sent upstream. And in many of my hospitals I used to run, over 100 hospitals, this number is closer to 50%. So you can see it's a one-way valve going up. So having said that, there's like areas, 5 domains, which we found both challenges and barriers. I just want to kind of quickly go over what those are. For people, there's shortages, as we talked about. There's not only shortages of the medical personnel, but IT personnel. The other thing is we found the kind of dislocation or the decoupling of being on call, because physicians used to be where they needed the hospital to fill their practices got full, they don't need to be on call as much, and with them saying they don't have to always be on call, you'll find a lot of times there are physicians in the area but not available for call. So that's a thing that's changed. In terms of quality and processes, most of these processes are at the local level. There's no system processes. We don't have good metrics, but the current systems of transfer are actually very delayed. A lot of unnecessary transfers, a lot of delays in care, and it's quite time-consuming and expensive, and time-consuming it takes away from other patients. And then the technology, we said, makes it hard to have interoperability or connectivity, which means that you evaluate a patient, you may not be able to connect, so you have to transfer the patient for an evaluation, right? You may not be able to collaborate. The finances are wrong in that they don't actually pay the physicians unless they see them face to face. They don't pay the ambulance service unless they transfer somebody. And the hospitals actually have to take everybody, and they have to pay for the transfers. And so it turns out that the hospitals, you know, because of EMTALA, what's interesting is that EMTALA was created to stop dumping. It's actually probably one of the leading causes of dumping in my view now, because the patients get sent to the hospital and then they're responsible to make sure the patient does not have an emergency. And since they may not have the capabilities, they have to send them somewhere they can be seen hands-on by someone else. And this is my favorite one, jurisdictional politics. And I go over this briefly. Again, it's very deep in the paper. But jurisdictional politics, state boards, hot topic. But licensing was put in for a good reason. It's now become a bit of a barrier. And my concern is that the patients and the diseases are free to cross jurisdictional boundaries, but the care is not. And that's a problem when you have an aging, growing population and more chronic disease, and you've got a shortage of providers. So why can't we get the best everywhere, right? And that's artificial. Second is the, in terms of jurisdictional politics, even credentialing, privileging at hospitals varies all over the place. A lot of specialists will not be in multiple hospitals because the paperwork is so different and so much time consuming to do that. In some states you have a uniform system. You fill out one form, you can apply to everywhere that way. Georgia is one, but that's another issue. And the last one is the scope of practice laws. You cannot have a nurse practitioner be exactly the same from state to state. You may not have a physician be state to state. So all these are artificial barriers to the ability to do a better job for our patients. So having said that, where do we need to go that is not stupid? Right? Not stupid. Again, going back to the medical student who said, everything you guys do is stupid. Well, let's see if we can do it someplace different. So I'll show you a little something. This is one of my favorite thoughts, and this is the Dennys Phenomenon. And I teach this to a lot of my residents. I teach this to a lot of my docs over time. Whenever they don't like the way things are, they don't like their patient satisfaction scores, that sort of thing. Basically, if you don't like the way the system works right now, it's probably because of the Dennys Phenomenon. And that means no one ever says, you know what, we went out to Dennys. They always say, you know, we ended up at Dennys. And so if you don't really have a plan to execute, then any place will do, and you end up where you end up. And so I'm a big believer that the time now is to redesign the system. A big part of that is the movement toward value. What that creates a business plan that says that a business model that says, you know what, we can do a little bit better. So the bottom line here, yeah, all this stuff, but the bottom line, if you want to stay financially viable in days of decreasing revenue, you got to lower your cost. And so we're going from cash is king to cost is king. And I've been here before when I went to capitated care years ago, but we have a lot of very inefficient, very expensive things that we do we can no longer afford to do. But the bad news is when you measure it in terms of quality outcomes, it's not patient-centered, it's not effective, it's not efficient, it's not safe, it's not timely, it's certainly not equitable, right? You've got different places having different metrics. So we don't even have the metrics for that at the higher level. So we looked at Regionalization 2.0 that says, look, let's look at the resources within the region and let's reconnect them. And so instead of being one way, you have a two-way, and you distribute that just-in-time delivery. And it's funny in a way because it's funny, you know, we don't have to have credentials or licenses to give you CME. As a physician, I can come in and teach anything at any time, and I don't have to do that. But somehow, to help my colleagues, we've made all these barriers. So I think it's a very easy way to do it together. But here's the bottom line. Specialized equipment and technology, that's fixed. Move that patient. Move that patient to that fixed asset. Specialized procedural skills like a cath lab or the interventional cardiologist, move that patient. But if it's cognitive skills and the knowledge is movable, move it to the patient. Push the button, like our medical student said. I push the button, I get what I need, right? Push the button, take care of that patient, allow these hospitals to maintain their capabilities, maintain their revenue. And by the way, these are big economic generators. Oftentimes, they hire a lot of people locally. We're seeing these hospitals going bankrupt because they transfer the patients up. You're then seeing businesses move out of town because there's no health care available. So it's really stupid. Did you get the stupid part? So my idea, look, this is not a top-down approach. This is bottom-up. This is about people coming together and saying, how do we use the resources locally to take care of our patients? It's market by market. It's relationship-driven. It's about putting the right infrastructure in place. But we're beginning to see it already, and that's what I want to point to is the fact that we're beginning to see the building blocks begin to come up. There's building blocks coming up. You need to use that to redesign. No more Dennys. You decide what you're going to do, and you bring it in saying, here's our goal as a system. Quality levels at the system. So match the patient's needs. Make sure that the system responds to the needs of a patient, not the patient responds to the design of the system. You know, Don Berwick always talks about every system is perfectly designed to get the results that it gets. So now we have to do is redesign that system, putting what we're trying to achieve. And what's great is those benefits extend beyond the patient, but to the region itself, especially in disaster or public health emergencies, okay? So we now move to the driving force being to get the right resource to the right patient at the right time, in the right place, and interesting enough, now people are saying with the right cost, because cost is king, and it's moving that direction. That's where telemedicine can do things. A lot of people focused on telemedicine as getting a lot more money to begin with, but in the real life it's going to save a ton of money, and that's going to be the big one. So let's look at the opportunities, the building blocks. Revisions of scope of practice laws are happening now, allowing more independence. We're seeing federal changes to hospital supervision rules, so you can supervise remotely or don't need that supervision for things like dietary, that sort of thing you used to. The growth of remote oversight for hospital functions, probably the best one here is pharmacy, where you can do it from remotely and oversee the techs. We're seeing the expansion of telemedicine. In my view, this is all brand new. Telemedicine, as much as we all know about it here, they're just waking up to it on the clinical side. Too often it's been an IT program. Now it's more of an operations program. They start looking for revenue, then they find they can do savings. And then virtual staffing solutions. You can have a full complement in your hospital of physicians just by pushing a button. And the public should know what that is. In terms of quality and processes, again, we're seeing the shift to value links the outcomes with cost, so the ability to measure becomes important. The growth, and I see this a lot, there's not as many mergers and acquisitions now. What you're seeing a lot more is new model formation, but new affiliations and networks. In order to make those power to work, you have to be able to connect them. And so that's actually the biggest challenge, connecting them both culturally and digitally, right? Put those two things together. So systems that bring those together are actually breeding grounds for good telemedicine and for better emergency care. And then you see NQF, National Quality Forum, started looking at measures that looked across a region. And then the last thing I've mentioned is this idea of Coop Atisha. And I'll give you that. I was meeting with the CEO of one of the one of the largest healthcare systems in the US. And he said, look, with all due respect, we've gotten really good at this lean and cutting costs and everything else. The truth of the matter is we have to start deciding what we don't do. We can't do everything. And so what that means is you have to learn how to do co-opetition, which is very big in the private business, other retails and others. So for example, Scotch whiskey is almost every Scotch distillery in Scotland makes single malt. But then what's on the market, 90% of it is blended. So you work with your friends to blend it. LinkedIn works with recruiters. They don't compete, though they compete, but they work together to help share information so they can help both do a better job. Automobile manufacturers often have other manufacturers make engines or batteries or parts for them in order to leverage that, not to start over again. We haven't done that in healthcare yet. We need to do that, but the basic characteristics is the lower cost, expand markets, increase the value of services you provide, especially as you move toward population health and others, and then cooperation, collaboration, and then co-creation, creating new capabilities. Emergency care fits very, very well into this model, especially with the types of patients we have. Other opportunities are the wide growth of EMRs and HITs. The movement to cloud-based systems for a lot of reasons, but one of the reasons is that at the smaller facilities, they really can't afford an IT staff. So it allows them to have things updated and become part of it. When the system updates, they update. So it's a nice thing in order to make equity occur. The growth of health information exchanges for us means that you can now look at the financial, you can look at the clinical, and we need to add resources to that. That what we call a care coordination network. And that way you can match the resources. That's another building block. The rollout of broadband and then increase and extended use of telemedicine, including other access points like urgent care, retail, workplaces, those sort of things for the longitudinal care. So this is actually some of the stuff we're doing. My co-writer for this was Dr. Brendan Carr. There's Dr. Carr in the middle of the night because he's not coming in. And he is looking over the shoulder of a resident and he's helping her do an ultrasound. And then he's reading the ultrasound, right? So just-in-time delivery of that ability, increasing her capabilities, not needing to transfer the patient. He actually can go to any ER in their network and help them do cardiac resuscitation and doesn't need a doctor because he can run it from there, okay? This is how portable it is. It's like our resident said, it's stupid, I can run it on my handheld. This is in Birmingham, I believe, looking at the tele-ICUs. This is a stroke center. So the bottom line is those are cognitive functions that are mobile and moved across. For finances, what's interesting, I think, is that the emerging networks are really moving more and more toward eliminating waste, cost, and I'd put debt on there, right? The payment models do look for risk sharing, so they derive collaboration and innovation, ways to help diminish risk, and share resources, the movement toward Coop Atisha. The payments are growing for telehealth and telemedicine, but I'll tell you, that's a false belief that they're all about getting the payments. It's about being able to cut your costs too. You know, there's a lot, every time you get a payment, if it takes you $30 to make $35, that's a lot of work. But for every dollar I cut goes straight to my bottom line, that's pretty good in terms of a business case. And the last thing is the rapid shift to patient as payer means that they're going to make decisions based on what the costs are, and they're going to start using services that allow them to get better care at a cheaper price. So they're the ones paying for it. So again, I've added the at the right cost as an important component of all that. The jurisdictional politics, we saw a lot about the state boards, I say adapting. We don't think they're there yet, but they're beginning to see that they have to find relevance that's a little bit different. There's also federal legislation to oversee some of that, maybe make national enabling of telemedicine. In fact, there's a meeting tomorrow looking at even some of the definitions, so that maybe they can change the definitions. CMS ruled about telemedicine privileges. You can accept one from another facility already. Facility privileging is adopting in telemedicine. It's funny, they're actually now coming out with one-pager credentialing because you're going to be working with a physician who's already there, right? So all you're really doing is consulting. And then you're seeing now, y'all may not know, but CMS just put out rules that if you don't have this disaster preparedness and you don't have these things, you lose Medicare participation. And so they're also at the same time that the hospitals are driving state HIEs, especially places like in the Gulf, where there's hurricanes knock out several different states at one time. You're seeing up in the Northeast, and so that's driving it. So just the last couple slides is that we had some recommendations that you build on these HIEs and HIX to create care coordination exchanges. They do this in Birmingham already. They keep track of all their resources. They did it back in California when I was at Stanford because of earthquakes, so we knew where things were. And you could move patients seamlessly between that. All you really need to do is share your data, organize and monitor resources, and match the needs. I said make sure you track and obviate unnecessary transfers. People don't really look and see what happens to the patients who are transferred and what happened to them. You need to do that, and then you see which patients. I started having some of our clients do that, and they found somewhere between 50 and 70% were discharged upstream. And so now they're putting new rules in, or looking at telemedicine to solve their problem. So look at your own stuff first, you'd be surprised. Standardized credentialing and then some transparency of local on-call, because the patient should begin to choose, and when they choose, you'll want to have telemedicine capabilities there. And so the big question is, who cares, right? So the way I look at this now is all about the business case. There you go, business case. The business case is that it's all about maintaining your margins. And if you looked at it this year, what was the most important thing that came out of the financial results this year is that costs are growing faster than revenue. In every private, nonprofit, everything, costs are growing higher. So you're not going to maintain margins. To maintain margins, you got to cut it. You want to decrease your waste, cost, bad debt. So don't generate all the charges if you don't need to. Do it what's reasonable and make sure you get it. Don't spend the money if you're not going to get the money back, right? Support transition to new financial models that allow you to do things like assume risk and population health by extending your geographic footprint and yet still having the information and matching the resources to the patient. It improves your operational efficiency. This is important. A lot of these hospitals, you don't want to build new beds. You don't want to staff more beds. If you improve your throughput and efficiency, you can actually double and triple your capabilities and your capacity and do a lot better. So it's about becoming more operationally efficient and allows the growth of new capabilities and models. So those are all things that putting these networks together that have telemedicine and match the resources allow you to do from a business case. Then my last comment is that emergency care professionals are built on systems thinking. You know, we built EMS and others, so they're much more likely to be systems thinking than the non-emergency care physicians. A lot of times people say, how do we fit in the ACOs? Well, my point is get a seat at the table. If there's no table, get your own. Start your own table to have the discussion. Be proactive and then build upon building blocks. People don't want to take risk, but they will build upon a success in the marketplace, and that's how a lot of any business is built. Proactively remove any barriers, and my point is lead it or lose it. So my last point to people is really, this is a great quote from philosopher Eric Hoffer. In times of change, learners inherit the earth while the learned find themselves beautifully equipped to deal with a world that no longer exists. And so my point is when people keep saying, where do we fit in? My answer is, why don't you tell them? Why don't you tell them? And I even look around with telemedicine. I see a lot of little pieces. But I keep waiting for the big vision out here, how it all fits together. And that's where it's going to really take off, and people can see it. They can use it as a prism to build the system better. And with that, I'll say thank you and open it up for any questions.
Anyone have any questions?
Thank you.
Sure. I have one, Rick. You mentioned the transfer of patients from the small hospital up the chain. Mm-hmm. If you don't do that, if you don't transfer patients, doesn't the smaller hospital gain reputation in the community and then people stop driving by?
That's a great point. As I said, I managed a lot of hospitals, over about 103 actually, and we had several of the smaller ones where patients were transferred so often for pulmonary, anything with their chest or head, or abdominal pain for that much, that the local people began to drive past the hospital, the 30 miles to the bigger hospital, because they wanted to at least have their car when they were going to be transferred, right? So two things happen. One is that you lose the capability at the local level to really care for these patients because there's no feedback loop, because no one calls back to take care of it. And secondly, the patients do bypass it and you lose reputation in the community. You're seeing these things such as LifePoint, Duke LifePoint, right? CHS and Cleveland Clinic and those sort of things, where you can push a button and the resources or the expertise comes to you. So now in the local community, I can get the same sort of expertise that I could get from one of these big names. So that's where that's all going to go, and that's why I tell you CME can be done across the border very easily without all the licensing issues. So I see that as one of the important things. And then the last thing I was going to say about that is that it's expensive to hire ER docs in the smaller hospitals, because it used to be you paid them less because they saw less patients. But since they spend so much time transferring and they feel they're by themselves, you pay them a higher risk premium because of the risk for being in a place without resources. So that actually also hits the bottom line. You can usually pay them less, they're better supported, and it's easy to retain and recruit docs. Yes, Phyllis? Well, the question is being asked is that some of the physicians, the consultants, think there's a level of risk without seeing the patient straight on. They don't, just looking at the CT scan that concerns them, right? They think there's a certain level of risk. One of my questions is that generational?
Oh, absolutely.
Yeah, so the answer is yes, but we find that because the younger ones don't really want to get out of bed. They could just, if they got an iPad, right? But the other thing is there's a lot of good models that show for stroke and all, where the decisions have been very, very good, and they've gotten better than what they've done in the past with telephone by using telemedicine, making sure the patient. So there's a group called what they call them stroke docs, right? They keep publishing these articles, and I think you're going to see greater acceptance of this. The big issue is, for what it's worth, when the physicians are paying for it, you'd be shocked how fast they change that idea. I need to see them in front of me. Because when you get into a capitated environment or a risk sharing where you're partially paying for all the tests that bring them back up and take a look at them, you do look for things that are cost effective. And then, as you know, the last thing is that it has a lot to do with relationships. Who do I trust? What is the system? How do we go back and do review? And what you find, someone gave a presentation earlier, they kind of put the systems in, did a lot of review, and then realized things were well and there was greater adoption. But changing physician practice is always a bit of a challenge. It always comes back to quality. Yes, ma'am. The points being made is that patients aren't necessarily satisfied being transferred. It's funny about that. Intuitively, you think they would be because you're sending them to a specialist. But the bottom line is that you've actually been able to find in these telemedicine programs where the patient satisfaction is quite high because of the rapid response. Just like waiting to get on the airplane, those delays kill you. And getting the rapid response, somebody cares very well, and you feel like you've gotten the right care, and you feel more likely to come back to that institution. The thing I found interesting is we look at the stroke programs. The stroke docs will tell you that they get a ton of calls in the very beginning, and then they start going down because the capabilities and the knowledge of that local hospital goes up dramatically because they're constantly giving feedback. In our current system, there is no feedback loop, so there is no growth. Thank you very much. Appreciate it.